All right, good morning, everybody. And we're going to go ahead. We'll start with your advanced organizer over schizophrenia. And this was a lot of matching, so it's a lot of terminology. So I'm going to run through the answers, but then I want to take some time, and if you have any questions about some of the terms, we'll try to clarify them now. They show up again, most of them show up again in the actual lecture, so it'll give us some time to kind of review and just make sure we're on the same page with the vocab. Okay, number 1 should be X, 2, GG, 3S, 4F, 5O, 6D, 7U, 8EE, 9W, 10V, 11L, 12C, 13N, 14R, 15HH, 16K, 17G, 18P, 19J, 20Y, 21FF, 22A, 23T, 24DD, 25BB, 26H, 27E, 28Z, 29I, 30Q, 31CC, 32M, 33AA, 34B. Okay, so if you missed any or if you have any questions, once again, you can go ahead and ask those now. I'll try to clarify some terms, but you will have another opportunity a little bit later in the lecture as well. So anybody have any questions or miss any? I see a few heads shaking no. I'm gonna scroll through you guys. So shake your head, yes if you have questions, no if you're good. No? Okay. All right. Hi, Jen. Hi, Deb. Hi, Shelby. Okay, so it seems like we're okay with the vocabulary, and I will help spot check you guys as we go through the lecture. So we are going to be talking about schizophrenia spectrum disorders. So it is important, for the most part, we talk about schizophrenia, but understanding that this is a spectrum of disorders, and schizophrenia is on the far side of the disorders, meaning it's definitely the most severe mental illness. It affects all aspects of functioning, and so everything else is considered less severe. And we'll talk about a few of those different diagnoses that go along with schizophrenia spectrum disorders. So the etiology or the cause, there's both inherited and non-inherited factors. So they believe that there's a lot of different neurotransmitters that are involved in schizophrenia. And the primary one, though, that we think about with schizophrenia is dopamine. So that there's excess dopamine in certain areas in the brain, particularly in the limbic area, and then not enough in the cortex of the brain. So again, I'm not usually asking specifics about brain structure, but more knowing that dopamine is the primary issue in schizophrenia. Some other etiologies, so older fathers, they believe that that is an issue because there are genetic mutations in the sperm as the male ages. And that, again, there are some structural abnormalities in the brain. And so when they do things like PET scanning on the brain of somebody with schizophrenia, they do tend to see like decreased volume, rate of blood flow, glucose metabolism is decreased, especially in the frontal lobe. And so there's also excess synaptic pruning, meaning that the brain is, getting rid of things that it probably should not be. So the frontal lobe, and this will hopefully make sense, the frontal lobe has a decreased metabolism of glucose, decreased blood flow. So the frontal lobe isn't able to function like it should. And the frontal lobe is what controls planning, abstract reasoning, decision-making, social judgment. So those are all things that you see as problems, huge problems in schizophrenia. Also early brain insults, meaning early brain injury, hypoxia, things like that. Comorbidities, so we do see a lot of different comorbidities with schizophrenia, whether it's dual diagnosis and substance abuse, or that could go along with nicotine, high rates of nicotine use in those with schizophrenia. But unfortunately, we also see high rates of suicide, a lot of depressive type symptoms, and sometimes it's difficult to tell what's depression, especially some symptoms of depression versus what's symptoms of schizophrenia. Anxiety, obesity, psychosis-induced polydipsia. So this I have seen. I've only seen it once. It's fairly rare, but it's where the person just feels like they cannot get enough water to drink. And so we had this patient in a psychiatric intensive care unit. And before we figured out what was wrong with him, he put himself into an electrolyte balance, had to go to the medical ICU because he just drowned out overhydration, water intoxication, just completely drowned out all of his electrolytes. And we had to, when we got him back from the ICU, we actually had to lock all the bathrooms and had to make sure that there were no cups on the unit, because if he got a hold of a cup, he would drink out of the toilet. He would, just anything. He thought that he was dying of thirst, basically. And it was all part of his schizophrenia. So onset, we want to make sure that we understand that the onset of this of schizophrenia does kind of change the prognosis. So the earlier the onset, so the younger the person is when they have symptoms of schizophrenia, the worse the prognosis is. And males do tend to have an earlier onset than females, so they do tend to have a worse prognosis. So the symptoms, a later onset is better. And again, our females tend to have a later onset, but the rationale behind that, the reasoning behind why it's better, is because the person is further along in their development. So a lot of times when somebody starts to have symptoms of schizophrenia, aspects of their development are really, they're halted. And so the person, like their psychosocial development, if you think about Erickson's, any of those type of things, they kind of get stuck there. They get halted there, and they don't necessarily go on in their development. So the younger they are, the less likely they are to reach their full potential. Additionally, does that make sense? Okay, I see if you head shaking yes. I just want to make sure. Yeah, we're good. Makes sense? Okay. So faster onset is also better. And that sometimes, again, sounds kind of counterintuitive, but basically, if we can see more of a trail, like looking back, that this person in their childhood, they were more eccentric or withdrawn, then that's a less favorable outcome than if somebody kind of just flips one day and has a psychotic episode. If somebody just has this psychosis and it's real fast onset, that usually has a better prognosis. It usually is easier to treat than if somebody has this kind of history. And part of that is because it probably happened earlier in life, that they really had symptoms. It's just we didn't recognize that those were symptoms until they had a more obvious presentation. A few things that they might even see. So research has shown they looked at excessive blinking in childhood as something that might be a precursor to schizophrenia. Another thing is that they did a retrospective study on those that were diagnosed with schizophrenia and found in their charting from like day one when they were born that they tended to be more awake than the average newborn would be. And so they think that might be almost like an early hypervigilance that you see with paranoid schizophrenia. So again, just another potential link there, not causative, but something that they see. So I mentioned before that certain drugs certain drugs can trigger a psychotic episode or schizophrenia in those that are predisposed to it through their genetics. And so marijuana, LSD, methamphetamine use, all of those things can potentially trigger psychotic episodes. And particularly our adolescent males tend to be very susceptible to this trigger, as well as some other things that they've linked with the development of schizophrenia is living in a city, and then of course parents with schizophrenia, which makes sense because that's a genetic link. Phases of schizophrenia. So the person, again, often has early signs. They might be shy, withdrawn, have poor relationships with peers, not do very well in school, kind of aloof, cold, not have that full range of emotions, so kind of a flattened affect. They may even have magical thinking. So that's, again, that's where they have the belief that their thoughts can do things. So if I think a bad thought about somebody, something bad will happen to them. So that's magical thinking. The prodromal phase of schizophrenia is early symptoms that are general, such as being withdrawn. So it's not really symptoms that we would directly link with schizophrenia really until we probably look back on it. Acute phase. So the acute phase is what we call the florid psychotic symptoms. So florid just means like acute, that they are in your face. It's very obvious. So you could probably use the term obvious psychotic symptoms, but they use the term florid to describe it. Stabilization phase is when those florid symptoms are gone. So they don't have like the major hallucinations, the major delusions. They're stabilized because the hallucinations are much quieter or only mumbling, or they're gone. So something along those lines where the patient is finally stable. And then the maintenance phase. So they may have some residual symptoms, but they're more subtle in nature. So again, it's those things that maybe for some people don't ever really go away. Some people live with voices their entire life. So for some people in their maintenance phase, those will be residual symptoms. For other people, it'll be more with just being withdrawn or being kind of eccentric, or maybe that magical thinking, flat affect. A lot of times flat affect does not go away. It's something that tends to linger. So when we look at assessment, there are lots of different psychotic disorders that fall into the spectrum. So anything from schizophreniform disorder, brief psychotic episode, schizoaffective, the one that's one that you should be able to identify or have an idea of what it is. So I'm not going to ask you about all of them, but schizoaffective disorder is actually very common in our hospitalized patients. And what schizoaffective disorder means, it means that the person meets most of the criteria for schizophrenia, but that they also, it's not to the level of schizophrenia, but they have a lot of the symptoms of schizophrenia, but then they also have a mood disorder. So on top of those psychotic symptoms, they either have depression or they have bipolar disorder as well. So it's considered not as severe as schizophrenia, but I can tell you acutely, sometimes those patients are just as sick, if not more sick than my patients with full schizophrenia, because they're manic, they're impulsive, they have mixed episodes, and they're psychotic. It's very much a debilitating illness as well. Schizotypal delusional disorder. So delusional disorder is the other one I want you to know. Okay. So delusional disorder, there's several different types in your text. there's anything from aromatic disorder, paranoid, so there's different ones. But here's the key. The key with differentiating a delusional disorder from any other type of disorder is that in the delusional disorder, they really just have one delusion. So they believe that the CIA is tracking them, or they believe that somebody is in love with them. I believe that there's a star that's in love with me, and they're not. So that can get into stalking issues and stuff. So sometimes, that's where you might see some of these delusional disorders. So there's two really main factors. So the first one is that it is isolated to one delusion. The second is that delusion is non-bizarre. Okay? So the delusion is non-bizarre, meaning that in the realm of reality that it could take place. Doesn't mean it's likely. It doesn't mean that you have any inklings to believe it, but it means that it could take place. So, do I believe that my patient is being tracked by the CIA? Probably not. But does the CIA track people? Yeah. So that's within the realm of reality. Okay, it's a non-bizarre delusion. Same thing with, do I believe that that Chris Pratt is in love with my patient? Okay, no. But does Chris Pratt probably have a relationship with somebody? Yes. Okay. So it's these. I've had patients who thought they were a pilot for Air Force One. So again, somebody's the pilot for Air Force One. So that's where you really have to be able to differentiate that. If my patient thinks that there's an alien growing in their stomach, that would not fit the criteria, because that is bizarre. Okay, symptoms. So it's very much split into these positive symptoms versus negative symptoms versus cognitive symptoms. So you do want to have an idea of what these different types of symptoms are. So the positive symptoms, what you tend to think about is that in a positive symptom, so if I have kind of like normal, so if you think about a normal line here somewhere in the middle, I can't tell if I'm even on camera here with my hands. So if you have normal line like here, your positive symptoms are going to be the stuff that's in addition to. So it's those delusions, it's those hallucinations, it's the stuff that's above kind of normal. My negative symptoms are taking away. It's a lot of the words that start with A, because it's inertia, evolution. So it's lacking or without. So it's usually easier to kind of think about them that way. So if we go through these, the first one is about delusions. Are there any of those delusions that you have questions about? This is your time to ask. So you want to make sure you understand each of those. Feel free to speak up. It's okay.
You know what? What is that second one? Grandiose?
So grandiose is when you have these big grand beliefs. Okay. So it would be like, I'm the queen, or I am the pilot for Air Force One, those types of things. Okay. I'm running for president. Any other ones?
What are the last two?
Erotomania has to do again with the like belief that somebody is in love with you. So it's kind of like romantic. You can kind of see the link there. And the nihilistic is kind of the belief that in non-existence, that you no longer exist anymore. It's a very negative type of delusion. It's still a positive symptom, but it's very much believing that you like don't exist. What about concrete thinking? I do want to make sure we understand the difference here. I'm seeing a few when we're checking either concrete versus abstract thinking in my clinical paperwork. I'm seeing people struggling with that a little bit. So I do want to make sure that we know what the difference is there. And so one way, I'm going to ask you guys this question, so I want you to participate. If I said, and I've actually done this in group, if I ask the question, tell me a time when the world gave you lemons and you made lemonade. What's the abstract way to answer that question? What's the way that most of you would answer that?
Add Tito's? No.
That's a concrete, okay, so that's a concrete way to answer that question, okay? So, and I've actually, in a group, had a patient had a card, and they were reading that question, and they go, oh, well, last summer, you know, we went to the store and we bought these lemons, and then we went home, and they proceeded to tell us how they squeezed the lemons and how much sugar they added to the lemonade. Okay, that's a concrete answer. So we ask those questions sometimes to see if our patient has an abstract or concrete response to see where their thinking is. So what would be somebody tell me an abstract way?
So would you say life's never given me lemons?
You could say that. I would doubt that that's accurate though, because I think right now you're trying to make lemonade from lemons, right? So we would look for a time for them to be able to give us an example of when the world gave them lemons. Now, so if somebody really says, I don't think, the world's never given me lemons, I've always had to go buy them, that's again a concrete response. Does that make sense, Jessica? Yeah, okay. So instead, if they gave us an example, I was in a car accident, and I, had my leg injured, and I was kind of not able to leave the house very much for a month, but I used that time to brush up on my Spanish. I was teaching myself Spanish. Whatever, it doesn't matter what the example is, as long as they are actually thinking about it in an abstract form and can give you an example. Okay, how about alterations in speech? Any of those you need help differentiating? You got to know them. Okay. Perception, alterations in perception, so hallucinations, which we've covered, and those are, again, any false sensory information. And then the big one that you need to assess for, if your patient has hallucinations, particularly if they have any auditory hallucinations, we need to make sure that we are assessing for command hallucinations, because those are a big risk factor for suicide if they're telling them to hurt themselves or someone else. So that's suicide homicide risk. Depersonalization, derealization, we good with those? See, yes, okay. Alterations in behavior. Any of those? Or, yeah, go ahead. I heard something. No? Okay. Paranoia. We know what ideas of reference are. I will give you a hint this week. The patient video for clinical has ideas of reference. So you should be able to pick up on those, okay? So you should see them in that video. Then we have the negative symptoms. So again, a lot of those A words are things that you would expect that the patient does not have or does not do. Are we good with those? Seeing some head shaking, yes. And then there's the neurocognitive symptoms. And And again, we just see it's those issues with executive functioning. It's those frontal lobe problems. So just can't have attention, memory, organized, plan, just disorganized in their thinking, and then mood. A lot of depression or dysphoria, suicidality. So in addition to assessing these symptoms, we want to make sure that we are also assessing adherence, family support, and any other conditions. Remember that a lot of these patients, they use nicotine, they have issues with weight because of the medicine, so there's all of these different potential medical issues and problems that they have difficulty with managing because of the issues with executive functioning. So we need to make sure we're looking at that. And then the adherence, I'm just going to remind you that with these patients, again, we need to know, is it a cannot or a will not? And a lot of these patients are a cannot because they don't plan. They're not really able to do that planning for what do I do if my medication gets low. Okay. So outcomes and planning, acutely, it's patient safety, medical stabilization. So we want to make sure that we're enhancing their strengths and minimizing their deficits, right? We're helping them do that. And acutely, we start identifying their discharge and follow-up needs for them and their family. Stabilization and maintenance during that phase, we want to definitely help with adherence to their medications and treatment. We want to help them understand schizophrenia, help them to participate in psychoeducational groups, and help with relapse prevention. So help them participate in psychoeducational groups and help with relapse prevention.
Can you repeat that one more time?
Sure. So for stabilization and maintenance, we want to help with adherence to medications, help them understand schizophrenia or whatever disorder they have, but this is mostly schizophrenia we're talking about. Participate in psychoeducational groups and help with relapse prevention. So self-care during implementation, we have to remember not to take things personally. Remember to care for yourself. It can be extremely draining to work with patients who are psychotic, especially if you have multiple patients who are psychotic at the same time. So just keep that in mind and make sure you keep your bucket full. But the other piece about, not taking things personally. So I have had patients who are psychotic, and one of my favorite stories is wearing my ID badge. And I was 22 when I started working on the psychiatric unit. And I had my ID badge, and my ID badge was from right before I got married. So I had lost some weight, whatever fit in my dress, okay? Got married and went on a 2-week honeymoon and put some of that back on, okay? So let's just say this is maybe a year later or so. And I had a patient, she looks at me, and then she looks at my ID, and then she looks at me again. She goes, "You've gotten fatter, haven't you?" And I'm like, "Yep, I put on a little weight since then." She's like, "Happens to all of us as we get older," and so it was, I just didn't take it personally. I didn't get upset or offended. She was just making an observation that I didn't look exactly the same as I did in my picture. And you know what? That's okay. But you have to learn that often people are not trying to be offensive. They don't have that filter. It's not part of, they didn't develop that, interpersonal communication skill. Okay, so it can almost be like childlike, where kids will just come up and be like, oh, you have a big belly, or, whatever they tend to say. Okay, so communication and interaction. So there's some different things that we might see with different types of patients. So the paranoid patient may say something like, he is trying to find out, maybe he and you are in on it together. And so we want to think about ways to address that if somebody makes a statement along those lines. The pages are sticking together. Hold on a sec. So he is trying to find out, maybe he and you are in on it together. So when we talk to patients like this, we want to try to speak kind of indirectly, not using like I or you. So we don't want to say I blah, 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 or you blah, blah, blah. We would say something more along the lines of, it might be, it's probably a little scary to think that people are plotting against you, that type of thing. But we're not starting it out with those type of statements. Identify with rather than fight the patient. So, I don't know, I kind of go back and forth. This is, your textbook talks about this. Identify with rather than fight the patient. Definitely don't want to fight them. I don't want to argue with any delusions that they have. I'm never going to do that. But I'm a little hesitant to kind of take their side as well. I usually try to stick to more of those kind of neutral statements, like this must be very difficult, or this must be scary. This must be a scary situation. So things like that. And you definitely don't want to rationalize. It talks about sharing the mistrust. So you might say something along the lines of, having people after you is scary. And so you're not agreeing with them, but you're validating what they feel. Does that make sense? Because it is. They believe that, and it must be scary to them to think that people are plotting against them. So, you also don't want to have a way for patients to kind of misinterpret what you're saying. So, very clear, simple communication. Did you have a question, Maria?
No, sorry. I didn't know it was unmuted.
Oh, that's okay. You just popped up on my screen. So, just wanted to see if you had a question. So usually I do a little scenario here, not really a scenario, but just kind of ask you to come up with some things. So take a moment and think about the hallucinating patient. So the patient tilts her head to the side and mumbles, "Not how, I can't right now," to an unseen person. What are you going to do or say? So what do you think? What are your thoughts? This person distracted? So how do you get somebody's attention if they're distracted?
Redirect them.
Redirect them how? How are you gonna get their attention?
Call them with their name.
Yeah, say their name. Very good. And so I want to redirect them. So say their name. Do I want to talk in a normal tone?
Yeah.
You think so? If you have people talking in your head,
Maybe louder.
maybe louder. Okay. Does that make sense? So this isn't the person who's deaf and we're screaming at them. This is somebody who has lots of people talking to them, but you need to be the one that is heard. So we would say their name, get their attention, talk a little bit louder than normal, and then redirect them to their feelings. That's what we always do, right? Is we want to, instead of them being really focused on the voices, we want to talk to them how they're feeling about those voices. What about eye contact? What are your thoughts about eye contact with somebody who's hallucinating? Do we keep it normal? Increase it, decrease it? What do you think?
I think you increase that so that they can actually like know that you're there and they can actually like physically see you.
So you can, I would say, for most patients, I'm going to follow their direction with the eye contact. So letting them know that I'm listening to them. Now, what if I told you that this patient is paranoid? What do I do with eye contact then? If you have somebody who's paranoid, do you want to make a lot of?
No, decrease it.
Decrease it if they're paranoid, okay? So I would, in general, I follow the person's kind of lead on the eye contact. If they're paranoid, you need to make sure that it's easy for them to look away or they will start to get suspicious of you, okay? Very good, guys. So the next one, the delusional patient. My mom controls my thoughts and I want her to stop. She is dead. Anything I might say? What do I want to focus on? What do I want to avoid?
I want to acknowledge that their mom like passed away and see how they feel about that.
So you talk about some concrete things, right? So you say your mom's dead. How are you coping with that? So you're taking what they say. Do I want to say, well, your mom's dead. How she can't control your thoughts? Nope. I saw Kayla. I saw you shake your head. No. Can you tell me why you wouldn't want to do that?
I don't know, it's kind of insensitive.
It definitely is insensitive, I would say in this case. But what am I doing?
You're arguing with their delusion.
I'm arguing with their delusion if I say that. And if I argue, you start to argue with somebody's delusion, what do?
They're going to get agitated and upset.
They start to get agitated and they dig their heels in. So I can actually make that delusion more fixed by arguing with them. Okay? So I want to keep that in mind. Don't try to reason with somebody who's delusional. Focus on concrete reality and feelings. The patient with associative looseness. The time is short and my watch is different. What to do? Down the rabbit hole, but then too late. I need to find the differences. Why me? What's an example of associative looseness? What do you do when somebody says that to you? What do we look for?
When you look for things that they're saying that kind of are the same.
Yeah. So we call that looking for a theme, right? So we want to look for a theme in their communication. And so what is driving this communication? If you had to think about like a theme or a need that they're trying to express, what do you think is going on here? Time is short. What to do? But then too late. Why me? What do you think that person's feeling?
You probably didn't have enough time, and maybe regretting it. It's too late, and why isn't she going through it?
Absolutely. So do they feel pressured? Does that sound like somebody who's feeling like they're under the gun for something, that they're pressured to do something? Absolutely. Yeah. So you reflect that back. It sounds like you're really feeling hurried or pressured that you have to do things. Can you tell me about that? Or maybe they're feeling a little bit scared. I could see that there too. Okay, so communicating with patients with different kind of needs or different difficulties in communication, you want to be able to identify some examples on what to do with that, and that will help you clinically as well, because patients need you to be able to think on your feet. Sorry. So the next part here is different types of therapies. So there's an assertive community treatment, and we don't see this everywhere, but in the places that it is, it's extremely helpful. So this is a community network that has basic living, work, social support, substance abuse help, family support, psychoeducational groups. So it's where everything is kind of connected. It's like a network. And that's supported by the National Alliance for the Mentally Ill. So that's what they would like to see. That's what we would hopefully see everywhere. Patients can also have family therapy, which, as always, family therapy helps with relapse prevention and helps the family become a resource for the patient and understand the illness. Cognitive behavioral therapy, they use goals and reinforcement, simple concrete instructions to help the patient change some of their behaviors. The thing with cognitive behavioral therapy, or really any of these therapies, is that because the patient tends to be more concrete in their thinking, they have difficulties abstracting what they learn and applying it to other situations. So they have trouble like generalizing. If I learn to communicate in a very specific manner with one or two individuals, I might have trouble taking those principles of communication and using it to connect with others in the future. Okay. And then social skills training, this is where they use rewards. So they use shaping to help with social communication. So like those nonverbals, the paralinguistics, interactive behavioral behaviors, and verbal content areas. So that's not just how to communicate, but the types of things. So those verbal content areas, like, is it appropriate to walk up to somebody and tell them that they look like they gained a lot of weight? Okay, probably not. And then the paralinguistics, or the interactive behaviors, where they understand that if somebody pauses and looks at you and kind of tilts their head a little bit, that means that they're probably waiting on a response. And so a lot of patients, they just don't pick up on those cues, on those nonverbals. So that's what that training is for. And then, as I mentioned, the recovery model for schizophrenia is really about empowerment. It's about teaching the patients how to advocate for themselves. So it has a lot to do with advocating and empowerment. Okay, I know we're about 45 minutes in, and we're probably about maybe about halfway done. The medications is huge with this. So I am going to go ahead and pause the recording. We're going to take 5-10 minutes so you can use the restroom, get a drink, and then we'll come back. Zoom recording. Okay, so we left off right with the antipsychotic medications. So I'm going to give you kind of just an overview of the antipsychotic medications initially, and then we'll talk about the first generation, which I usually use the term typical, and I do use the term typical on your test. Okay. And then second generation, or atypicals. And so atypicals, again, are what I usually term them. Then we're going to talk about, after that, we talk about some general teaching and things, and then we talk about the major side effects and what we do about them. And there is a chart in your book, so you are going to want your textbook handy, that talks about a lot of these. And I believe that it is .268 is the page you're going to want to be on in your textbook. Okay, so antipsychotic medications overview. So these do tend to cause some emotional quieting. There can be some sedation with some of these medications, especially if given, IM. The sedation usually happens within an hour, and the antipsychotics usually effect usually happen within a few weeks, but they don't get full effects until about 6 to 8 weeks. So we do need to make sure patients and families know that they're going to see some changes, hopefully, but that it takes a while to get the full response. Now, remember we talked about, those that have like that psychotic break and they have those really fluid type of symptoms, how they usually respond better. Well, part of that is because the medications that we have work best on the positive symptoms. Okay. We don't have a lot of medications that really work well on the negative symptoms. The atypical antipsychotics work better than the typicals on the negative symptoms. And then aripiprazole, which is technically in a class, it's called a dopamine stabilizer. That's technically the best one that we have to work on the negative symptoms, because what it does is it kind of helps boost dopamine in areas where it's low and decrease it in areas where it's high. So that's really the best medication that we have. And your textbook kind of characterizes it as an atypical antipsychotic, when truly it is a novel. It's truly kind of in a category by itself because it's a dopamine stabilizer. Okay. As I mentioned, the more bizarre, the more fluid the symptoms, the better the meds work. And then just keep in mind that the symptoms don't always go away, but they might be doubted, they might be lessened. The person might end up with mumbles instead of, conversations that they hear all the time. So just keep that in mind. There is research that's been done, and they believe that the medication's long-term use may actually cause damage to the brain, to the structure and the functioning of the brain. So these are the best things that we have for these patients with these really severe mental illnesses, but it doesn't mean that it doesn't come without consequences. And then we also want to keep in mind that every time that a patient goes off an antipsychotic, it can be harder to stabilize the patient until the person is really no longer responsive to the medication. So they may have to switch medications, and it can be harder and harder to find something to work for them. So adherence is so important. And it's such a big reason why we have such a high rate of recidivism, which is reoccurring hospitalizations. So recidivism is getting rehospitalized pretty much for the same thing. And that's why we have such a high rate, is because of non-adherence. Also, antipsychotics should, particularly your newer ones, should not be used in dementia-related psychosis. They can cause, there's like a pneumonia or death that they can cause. So the first generation, or the typical antipsychotics, primarily work on dopamine, but they do hit other receptors, which is other neurotransmitter receptors, so which is why they cause so many side effects. So they also hit the norepinephrine, the histamine, the acetylcholine. They tend to cause more extrapyramidal side effects, and I know you're familiar with that term now, so EPSEs. They do tend to elevate prolactin levels, and we're going to talk about what that means when we talk about side effects. And they help relieve or eliminate hallucinations or delusions, but they do have anticholinergic and antiandronergic effects as well. So we'll talk about what those mean here in just a moment. There's the typical, so the older medications are split up into 3 categories. So they're low potency, which is like your thorazine, chlorpromazine, or Mellaril, which is thioridazine. And those thorazine or chlorpromazine was our first antipsychotic. So that's kind of something specific about that. It does sedate, but it has less extrapyramidal side effects that can cause hypotension. Now keep in mind that the potency, so they're either low, medium, or high potency, and their side effect profile changes slightly based on which one they are. So the anticholinergic, anti-androgenergic effects tend to be a little bit more in the lower potency ones, but they tend to have less extrapyramidal side effects, okay, than your higher potency. So more anticholinergic and anti-androgenergic effects, but less extrapyramidal effects. The moderate ones just don't really fit into a category, so that's loxapine is your most common, or perfenazine. Perfenazine, they do use, I don't see that one very often. Loxapine they use if somebody needs to lose weight, can cause weight reduction. And so again, that one's just kind of in the middle. And then your high potency, of course, we have the haloperidol, flufenazine, and then the trifluoperazine. And these we do see, okay? So we do see all three of those. These are your highest potential for extrapyramidal side effects. So that's important to understand. They don't have as much anticholinergic and anti-androgenergic effects though. Okay, so it's kind of, you've kind of flipped them based on if they're low or high potency. Flufenazine has a long-acting form, so it has a decanate. So it's DECANOATE, which if you see the decanate on the end, then that means it's a long-acting, so they might only have to take it every few weeks. So they would get an injection every few weeks. Haloperidol is also less sedating, but it is, again, like the highest risk medication that we have for extrapyramidal side effects. It also works really well in violent behaviors. So patients will get an injection of haloperidol when they are violent. So that's something always to keep in the back of our minds, that they order that frequently. It is also available, yes, I see people shaking their head, yes, that is ordered frequently, sometimes along with some Ativan. So it is available in a long-acting form, a decanate. So again, they would only have to take that every few weeks. So it has a short-acting injection where I give it to you now and it's gonna calm the person down, or it can be given in a decanate form where it lasts for several weeks. This medication does tend to be, it's been more tested than any medication that we have. So it does work well in the elderly population and in children. Okay, so they do use this in both of those specialty populations. Our second generation, or our atypical antipsychotics. Well, let me ask, are we okay with the typicals?
Yeah.
A lot of this information is on your flashcards, right? Okay. And then we have the atypical. So these tend to block dopamine and serotonin. They don't have as much extrapyramidal side effects, which is good. They do treat the negative symptoms better than the older medications. They don't have a lot of risk for tardive dyskinesia, which we're going to talk about here in a little bit. They don't elevate the prolactin levels and therefore don't have the prolactin level side effects. However, here's the big kicker with a lot of these medications, is that their metabolic effects, they can cause severe weight gain in patients, which can lead to diabetes, cardiovascular disease. They can cause dyslipidemia, hypertension, premature death. So we have to watch these patients closely and monitor, their weight and how they do in reaction to these medications with their metabolic effects. Other areas where these medications are helpful is they can help with anxiety, depression, suicidal behaviors, and help increase cognitive functioning. Okay. So here, there's a lot of medications here. You do need to know if I put it on flashcards, you want to know the specifics, okay? So that is important. And I'm trying to point out the things that are most important about each medication. So the first one we're going to talk about is one of the most effective medications that we have available. However, its side effect profile bars us from using it except for in those most severe cases where patients are not responding to other things. Okay, so the first one is clozapine. We want to note that cigarette smoking can cause decreased levels, but here's the kicker: it can most of these medications can cause an agranulocytosis. Okay, however, it is more common. It's still rare, but it's about like 1% of cases of people that are on clozaril can end up with a agranulocytosis, which can then be deadly. So we have to watch for symptoms. We monitor white blood cell counts. And in fact, most of the time, you know, when they're first started on it, they take them like weekly and then decrease it gradually to usually about monthly. I think sometimes they can go every 3 months if they've been on it for a while. But the pharmacy, without white blood cell count levels, they can't refill the prescription. So they have to make sure that these patients are getting their white blood cell counts and that the patient is tolerating the medication okay. So besides monitoring that, we monitor signs and symptoms of infection. So we watch for things like sore throat or sores in the mouth, fever, and then of course that neutrophil count. Clozapine can also cause seizures, which is not uncommon with these medications. It is fatal in overdose. And then one more important thing is if the patient ever has to stop this medication because of a granulocytosis, they can never restart it. Okay, it means that they didn't tolerate the medication, that it's potentially deadly for them, so they don't ever get to take that medication again. Now, if they just stopped it for, you know, non-adherence, that's different. They can restart it. But if they had to stop because of a granulocytosis. Okay, so next one, olanzapine. Olanzapine causes a lot of weight gain. It's used for acute mania or bipolar disorder. It does cause the hyperprolactemia, which we'll talk about what the prolactin levels, what that means. And it does have a short-acting injection. So sometimes people will get an injection of olanzapine to kind of help sedate initially. We talked about that with bipolar disorder, that they might get that initially to kind of help just quiet. And then they could be on it orally as monotherapy as well. Risperidone is one of the most frequently prescribed. It's usually tolerated pretty well, and it does have a long-acting form also, which is called Consta. So it's Risperidol Consta would be the long-acting that would only need to be taken every few weeks. Now, Invega, paliperidone. This is an exciting medication. It first off it was the first medication approved for schizoaffective disorder specifically, so FDA approved for that. We do want to, when given orally, this medication should be given with food. So this is one where it needs the food to absorb properly. Then it also has a form, there's a 1-month form and there's a 3-month form, but they're called palmitate. So it would be paliperidone palmitate, P-A-L-M-I-T-A-T-E. And that is the long-acting form. So what they do is they give they make sure the person's on it PO for at least a month. Then they can give them 1-month long-acting form. Then they need to make sure that the patient's on the 1-month form for 3 months. Then they can give the 3-month form. Does that make sense? That they want to step it up, make sure the patient tolerates it. You don't just want to give somebody a medication that lasts in their body for 3 months. Because what if they're allergic? What if they don't tolerate it? What if it causes side effects that they can't deal with? Okay.
One more time. Sorry.
Again?
Can you repeat the long acting one more time?
Sure. Palmitate. Palmitate. So the next medication, extremely popular, Seroquel or quetiapine. And this one it's usually titrated. It's sedating when it's initially started, especially. And so we always give the largest dose at night. It can cause cardiac dysrhythmias and syncope, so we need to be careful with it. But you'll often see this when the patient first starts on it. They might be on like 25 milligrams 4 times a day, or 25 milligrams 3 times a day and 50 at night, something like that. And they just gradually kind of increase it. And then usually after they're on it for a little while, they'll put the whole dose at bedtime. Quetiapine was one of the medications, or is one of the medications also, that we talked about for helping with depression as well. Cash, my dog's whiny. I apologize if you can hear him. Ziprasidone is another medication that helps with depression and anxiety. It does cause a lot of GI symptoms, which may be part of the reason why it has less weight gain than some of the others, which is important, because any of them that cause less weight gain may be something we switch somebody to who's gained a lot of weight from their medication. This one must be given with food. Once again, this is not a suggestion or not just to decrease the GI symptoms, but actually because it needs that to absorb better. They should be getting a baseline EKG and monitoring their cardiovascular status. Ziprasidone does have an injectable short form as well as your PO. And just as a side note, just kind of an anecdotal thing, is that ziprasidone, some people will have one of their GI symptoms is a very specific flatulence that has a very specific odor to it. So my dog is being ridiculous, but so there are times where I could walk down the hallway and be like, oh, somebody's on Geodon in that room, and the odor kind of comes out. So if you ever notice a very distinct odor, it may be a Geodon GI side effects. So lorazepam is a medication given once nightly with food, at least 350 calories. It makes people sensitive to heat, but it is metabolically pretty neutral, which is great. Iloperidone, that's where I'm at. Okay, it is given twice daily, titrated over 4 days. It's not for people with cardiac conditions. Acetylpine is a sublingual, which makes it suicide proof if it's swallowed. So if the person doesn't let it melt, and absorb sublingually, then it's not going to have any effects. And then brexpiprazole is one of the newer medications you've probably seen. Rexulti. I don't have anything specific about that medication, just kind of knowing it's one of the newer atypicals. I gotta pause. I'm sorry. Okay, sorry about that. So the novel or third generation antipsychotic, again, I kind of have it separated out, although your textbook does not, is a dopamine stabilizer. So it's the best thing that we have on the positive and the negative symptoms. I'm not saying it's great, but it's the best that we have. So aripiprazole does not tend to cause a distressing weight gain, and it has very few side effects. Headache, anxiety. The anxiety, it actually can help with anxiety, so the anxiety usually goes away. And then insomnia. I take this medication to help with my depression. So it's at a low dose. If you take it for depression, usually like 2 milligrams, 3 milligrams, something like that. And then usually for psychotic symptoms, it starts at least 10 milligrams. So it's a very different dosage depending on what you're taking it for. And I can tell you the insomnia, mine was like an early waking. I would wake up every day at 3 a.m. And it lasted about a week. And then after that, no issues. I've tried titrating it, or I've tried coming off of it. Same thing happened. So let your patients know that there does tend to be a little bit of withdrawal from this medication. Nursing implications. So again, most of these, unless I said otherwise, most of them have a lower lethality in overdoses. We have to be careful with the first trimester of pregnancy because it can cause, and we have to watch it later in pregnancy as well, because it can actually cause extrapyramidal side effects in newborns. It can cause that sudden death or pneumonia in older patients with dementia related psychosis and lots of drug interactions. So with patient teaching, we want to use discretion in selecting education. So if you're going to print out something for patient education, which we need to do, we want to make sure that we're highlighting it, that we're going through it, and that we are hitting the top points, pointing things out that are most important, and not just letting the patient kind of read the whole, I mean, they can read the whole thing, but not leaving them to their own devices to kind of read into what we are giving them. Will you let the dog back in, please? And shut the door, please. Thank you. We want to give them simple written instructions on the benefits and side effects, as well as how to cope with the side effects. So if we are telling a patient that these are the side effects that they might experience, we want to tell them what they need to do about it. And so that's what the kind of the next page is about those side effects and what to do. Some general things is we usually want them going into like hot tubs and stuff because of hypotension that they can get. We don't want them to abruptly withdraw from the medication because they will have symptoms. We want, a lot of them cause photosensitivity, so we want them to use sunscreen, take the medications as prescribed, and then reporting anything that would indicate a blood dyscrasia. So anything from agranulocytosis or anemia, bleeding, anything along those things, and definitely drinking plenty of water. When we're giving these meds, we have to watch for cheeking. I think I've mentioned that before, but patients are very, very creative. And also we want to note that a lot of these medications come in different forms. So if you do have a patient who's cheeking, then we might need to look at, a decanate type of injection or some other depot type injection where it lasts long term. So a palmitate, paliperidone palmitate, the decanates, the Invega Sustaina, stuff like that. The other thing is that sometimes they'll come in like syrups or suspensions, like similar to like a cough syrup. And that can help if somebody's cheeking as well. Tablets, dissolving tablets, lots of different choices. When a patient does not respond to treatment with these medications, we do need to ask ourselves, is this patient actually taking the medication? So is this an adherence problem? And have they given the medication a fair trial, usually 3 to 6 weeks, depending on the medication? So we do want to ask, ourselves and the patient those things. When we're talking about caring for patients and families, we need to make sure that the patients understand that this is likely long-term use. This isn't something like depression. Patients can sometimes come off of those, or anxiety. With schizophrenia, bipolar disorder, the patients are usually on these medications for the rest of their life, or some type of medication. We want to help the patients and their families understand that just because these are mental illnesses doesn't mean we should be treating them differently than a physical illness, because we know now that there's physical causes for all of these things. We teach coping skills, and remember that the family may be able to help identify some of the side effects that maybe the patient isn't even recognizing, help with prescription refills, and then adherence. Okay, so this last page here is a lot of information that is important information. So when we think about the antipsychotic side effects, a couple things. We need to know, one, that they decrease seizure threshold, which means it increases the likelihood that the patient will have a seizure. So we do need to be aware of that. Then we have the anticholinergic effects. So I'm actually going to ask you, I'm going to have you write these down, and then I'm actually going to ask you to do it with me. And those of you that are on camera, I'm going to watch you to make sure you're doing it with me. But we have cognitive impairment. These are your anticholinergic effects. Cognitive impairment, blurry vision, dry mouth, tachycardia, urinary retention, constipation.
You said urinary what?
Retention, constipation. Okay, so put your pens down for a second. This will help you, I promise. And I see people doing this on the exam. So this obviously is tested material, okay? So you're going to start here. Cognitive impairment, blurry vision, dry mouth, tachycardia, urinary retention. I'm over my bladderish. And then go towards your back, constipation. Okay, it's like the Pepto-Bismol commercial, right? But if you can remember those are your symptoms of the anticholinergic effects. And so we need to make sure then that we're telling them what to do. Some of it we just monitor, okay? We tell them they need to report, so we can check for bladder distension. We can use bladder scanners. We can make sure that they're telling us about how much they're urinating. We are trying to prevent constipation, right? Fluids, fiber activity. That can help a little bit with the tachycardia as well, although sometimes I'm just, like for me personally, I'm just tacky from my medications. I always run, not always, but I'll get into the low hundreds a lot. Blurry vision is just a safety thing. There's not a lot we can do for that unless it's just dry eye, which sometimes is the case because those anticholinergic effects really dry things up. Sugar-free candy they can use for the dry mouth. And then just safety type things, especially with cognitive issues, vision issues. But we do need to keep in mind, this might not make sense quite yet, but the extrapyramidal side effects are treated with anticholinergic medications. So if I'm giving the patient an anticholinergic medication, that's going to make the anticholinergic side effects more intense, because of course anticholinergic medications have anticholinergic effects. Does that make sense? Maybe, not sure. I'll say it again here in a few minutes and we'll make sure it makes sense, okay? We have to watch for any cardiac effects, so EKG changes. So some of these medications, especially like ziprasidone, we want to watch for EKG changes or make sure they have an EKG first. The antiandronergic effects. So orthostatic hypotension is one. This is more likely to happen in older adults. And if it does happen in younger adults, it usually stabilizes. They'll usually have their body will accommodate within a few weeks of starting the medication. So we don't usually expect them to continue to have the hypotension, but our older adults may. So we have to watch for safety and fluids. Endocrine side effects, so those prolactin levels that we talked about being elevated can cause menstrual changes, impotence, feminization, gynecomastia, which is gynecomastia. So that's in men, and then libido changes in women. What is gynecomastia?
When men grow breasts.
Yes, when men develop breast tissue, yes. Which, I mean, you can imagine that that's pretty discouraging to some men, and they may have to have that breast tissue removed. Okay, also under endocrine effects is that insulin resistance and metabolic syndrome. Did you guys learn about metabolic syndrome in Med-Surg? We're not sure. Any idea what metabolic syndrome is? So it's a syndrome that usually comes along with like people that have gained weight or have a, so it has to do with their circumference, their abdominal circumference. So we think about that as one of the issues. Then, so it's waist circumference, elevated triglycerides, elevated blood sugar, elevated cholesterol, elevated blood pressure. And so when we talk about metabolic syndrome, that's usually before somebody ends up with diabetes, and they just can have this whole cluster of like heart attack, stroke type of precursors. That's what metabolic syndrome is. And so when we talk about these medications, especially the atypicals, the newer ones, that's why when I said like one of them is metabolically neutral or aripiprazole doesn't have a lot of those same side effects. That's why it's important to know those ones that don't have all the metabolic issues that go along with them, because they can be very distressing to the patient and cause a lot of, morbidity. So the insulin resistance can lead to type 2 diabetes. And so what we actually do is we monitor waist circumference and BMI on patients. So a lot of times those things are done when they first come in, and they may be done when they're discharged, or if they, on an outpatient basis, they might get that done on a regular basis. As I mentioned, there's lots of sexual side effects. There's gastrointestinal effects. So weight gain is a big effect, especially the newer ones. Neuroleptic malignant syndrome is one of the effects that can be deadly. So neuroleptic malignant syndrome is lethal but rare. And what we see with this, so some of our first signs and symptoms are muscle rigidity, and then they can end up with a fever that can go into hyperpyrexia. And then of course the patient's tachycardic because of that temperature increase. So they can go from stupor to coma within hours or years of starting an antipsychotic medication. And it can progress in 24 to 72 hours. So they can progress through this illness to death in 24 to 72 hours. It happens very rapidly. And the rigidity, so I've had one patient that I know was diagnosed, it wasn't my patient, but a patient that I saw that was diagnosed with this, and another patient that I am fairly certain had it, but it wasn't diagnosed yet. So I was helping get a patient into like a geriatric chair, and the geriatric chair had to be reclined. And this person was so stiff. I don't know if you can see, but if you think about it, they call it like a lead pipe rigidity, where their arms and their legs, like you have to like really push them to get them down, and they're just kind of stuck. So almost like a Tin Man type of thing. So it was very pronounced, and this patient happened to be a geriatric patient, so they didn't have hyperpyrexia right away, and so they were hesitant to diagnose, which this person could have died because it wasn't diagnosed just based on the rigidity. They waited until the person ended up with a fever and then sent them to the intensive care unit. But that's where these people are treated, as in the intensive care unit, not on a psychiatric unit. They don't have the equipment and things for that. So the treatment is to discontinue the antipsychotic immediately. So it's to discontinue the antipsychotic immediately. We monitor the patient. There are some medications that can be given. So dantrolene can help with muscle spasms. If you look at page 268 in your textbook, part of that table is specific to neuroleptic malignant syndrome. We monitor fluid balance. We decrease their temperature, so it's a lot of symptom management. We correct any electrolyte imbalances. They could be given the bromocriptine instead of the dantrolene, or sometimes in addition to. Monitor for dysrhythmias. And the earlier this person, the earlier that it's diagnosed, obviously the more likely that the patient will recover. Okay, so, and then we mentioned the agranulocytosis and liver impairment, and we talked about, really just monitoring for the agranulocytosis, and then they might have to discontinue that medication because of it. So the extrapyramidal side effects, okay, the extrapyramidal side effects that I want you to look at, I want you to look at that table on page 268. And there's several of them there that we need to be familiar with. So the first one is pseudoparkinsonism. And this is where the person will do like a pill rolling, kind of like they have a pill between their fingers like this. And they can get the shuffling gait. They look like somebody who has Parkinson's disease. That shuffling gait where they kind of lean over and then go to shuffle, and they're kind of off balance forward. They can have those things. They can have drooling and that stooped posture. So here is where they would likely take a PO medication for that, and we're going to get into those 3 medications here in just a minute. But the trihexyphenidyl PO is a common treatment for that, or Artane. Occasionally they'll use benztropine PO as well. Acute dystonic reactions. So in acute dystonia, they can have the aposthone. I haven't really seen this one. Aposthetonos, and that's where they're like heightened. So everything would kind of be up and kind of back, and everything would be kind of tilted up. That one I have not seen. The oculogyric crisis or torticollis, I've seen those. So torticollis isn't in here, but it is a type of acute dystonic reaction, and it's usually when like the head or the back will get twisted, and so they'll be kind of stuck like that. If you go like this and push it back, they can hold it back for a moment, but you let it go and it's going to snap back like that. So that's a torticollis. And it can happen with the neck or it can happen with the spine. The one that is very distressing, I'm gonna take off my glasses, is a oculogyric crisis. And it is where, so I had a patient come up to me and his eyes are flipped all the way up in his, I can hardly see anything but white. Okay, so it's like flipped up in his head, and he's like, Nicole, and he leans over and he's able to focus on me for a minute. He's like, something is wrong with my eyes. And as soon as he stopped talking to me, they flip right back up in his head. Obviously distressing. So that's why these are called acute dystonic reactions, because they're a muscle spasming. And for him, as they say in here, he got 50 milligrams of diphenhydramine IM like that, and it stopped it. So there's really those 3 medications that, and you have those written out. There's the benztropine, the trifexahenadril, and Benadryl, diphenhydramine. And the IM ones, you're going to use the IM ones, or you can give diphenhydramine, or you can give diphenhydramine or benztropine IV, but you have to have IV access. So if you're working on a psychiatric unit, you often do not have. So we usually give IM injections of those, and those are going to work within 10, 15 minutes or faster. And it did. It worked like a charm. His eyes were fine. We just had to watch that medication. I think we decreased the doses, switched into something else. But you can imagine how frightening that would be to a patient to have their eyes stuck in the top of their head. Akathisia is this inner restlessness, so they'll move around a lot. Unfortunately, akathisia doesn't respond really well to treatment, so usually to other medications, the anticholinergic meds. So usually they will just either decrease the dosage of the medication or switch medications. But it's very distressing. I mean, they'll describe it as an inner restlessness that they really can't get rid of. And then tardive dyskinesia. Some will say it's an extrapyramidal side effect. Some kind of put it by itself. It just depends on what source you look in. Tardive dyskinesia usually happens after long-term use of an antipsychotic. That's why it's tardive, which means slow. Okay. They can have issues with their mouth, their face, their trunk, their limbs. But most of the time what you'll see are these facial movements. And it often starts with what they call as a veniform tongue movement, which is like a snake. So they'll be talking and it'll kind of just stick out. And you'll see a lot of like mouth smacking type of stuff. So it's a lot of facial movements. They can have some difficulties with swallowing. You can see a lot of like hip movements and jerking type of things, and a lot of kind of spasm type of things with the arms as well. So unfortunately, there is no known treatment for this. And if it's not detected early, it can be permanent. So there is something called AIMS testing, AIMS. And again, like most things, I never remember what they actually stand for. But the AIMS testing, it's right here, Abnormal Involuntary Movement Scale. The AIMS testing, they do that a lot on an outpatient basis. Like every time somebody comes into the outpatient clinic, or at least monthly or whatever, they'll do an AIMS test on them so that they can try to detect those things early. And when I mentioned that sometimes family members are able to detect some of these side effects, they might notice some of that abnormal movement and stuff, especially with the face, before the patient even realizes they're doing it. So early detection is our best key, is our most important thing with this. And a lot of times they will discontinue that particular drug that they believe is causing it. So that table is very important to be familiar with. Are there any questions about those side effects and things so far, the extrapyramidals and just the general side effects of antipsychotics?
What were you saying that you said you were going to touch about it again? Something about the side effects are greater when there's more than one, or I forgot what you were saying about
Yeah,
it.
that's what we're coming to next. That's going to be the next thing, Shelby.
Okay, thank you.
Yep. Any other questions right now? Okay. Okay. So when we talked about the treatment for a lot of these extrapyramidal side effects, we mentioned 3 different medications. Now, what is helpful to understand is why do these side effects happen to begin with? So the extrapyramidal side effects specifically happen because in the brain, there is a balance. I'm not saying that they're equal, but there is a balance between dopamine and acetylcholine, okay? So those are normally in balance. When the patient takes a antipsychotic medication, it decreases the dopamine. So that's why these side effects are more in our older medications, our typicals, and a little bit less in our atypicals, and rarer in our dopamine stabilizer or novel medications, okay? So it decreases the dopamine when we give that antipsychotic medication, and it puts the acetylcholine dopamine balance out of whack. So it's no longer in balance. So the excess, now we have acetylcholine in excess of dopamine. Does that make sense? Okay, because we've given a medication to decrease the dopamine, so now there's like this excess of acetylcholine. So what we do is we give anticholinergic medication, or you can think about them as anti-acetylcholine medication. It works on acetylcholine and it decreases that neurotransmitter in the brain to try to put that back into balance. Now, if I give an anticholinergic medication, every medication has side effects, right? So if I give somebody, and let's say they're on haloperidol, that's the most likely to cause an extrapyramidal side effect. So they're on haloperidol, they do really well on it, but now they're starting to have pseudoparkinsonism, okay? So now we're gonna add that trihexyphenidyl or artane to treat the pseudoparkinsonism. Now I know that haloperidol has not as high of anticholinergic effects, but still has some. Now I'm giving them an anticholinergic medication, which of course has an anticholinergic side effect profile. They're not even a side effect, they're just the effects of that medication. So it intensifies the cognitive impairment, the blurry vision, dry mouth, tachycardia, urinary retention, constipation, because now they're on 2 medications that have that anticholinergic profile. Does that make sense? I got a couple heads shaking yes. Are we okay? That's probably the most confusing point to understand. Okay.
So you just double up the medication, so then you double up on the side effects.
Yeah, I mean, we're not. Yes and no. I don't want to say we're doubling up on the medications. We're treating one side effect and causing other side effects, right? So, because anytime we add a medication, we're causing more side effects, right? There's no medication that's completely without potential side effects. So it's kind of, are the side effects so bad that they need to stop, or can we treat it with another medication and those side effects aren't as bad? Does that make sense, Jules?
Yeah.
Okay. So the 3 that you need to know, and you already know the side effect profile because we went through them, are, as I said, the cogentin, the benztropine, which can be given PO, IM, or IV. The artane or the tifexahenidil, which is only PO. So we usually only give that for things like pseudoparkinsonism. They try it with akathisia sometimes, but it doesn't usually work really well. They usually prefer to switch drug instead of adding an anticholinergic. And then diphenhydramine, which is PO, IM, or IV. So an important thing to recognize here are, and I told you these for a reason, as to which ones are available in which forms, so that if you were given an acute dystonic reaction, which ones do we want to use?
The IM.
Yeah, our IM, if we had IV access, great. Normally that's not the case, but we would want to use either benztropine or diphenhydramine. Those are the orders that we would expect because they're IM. Okay. I know those of you that are at Flower, a lot of your patients will have benztropine as a PRN for extrapyramidal side effects, and then orders to call the psychiatrist after administering. You know, so they'll kind of have those PRNs just available. All right, I know that's a lot of information, and I just need to know if anybody has any questions. Do you understand the meds?
Can you repeat those last 3, the routes?
Yes. So basically the benztropine, diphenhydramine are available in all 3 forms, PO, IM, IV. And then the trihexyphenidyl is only PO. Okay.
Thank you.
Any other questions? Are the flashcards helping? Was some of this review, I mean, was a lot of this review from the flashcards at least? Okay. I made those right from lecture, so please use those. Otherwise, everything is uploaded, so all of your clinical paperwork is uploaded for the week, as well as the case study that's due on Friday. So keep those in mind, and they do reinforce this information. So you do have a patient with psychosis or schizophrenia. It's all meant to reinforce all the information that we just discussed. And I think that's it. I'm going to stop the recording.